All right. So this is a 2-year-old, 7-month male domestic short-haired cat named Giuseppe. So we have a left eye, which was blind with profuse tearing and unusual, uneven, and heavily pigmented corneal surface. And as you might expect, they could not see inside this eye. The other history that is of importance is that he was found by his current owner 2 years ago. So when he was about 7 months old as a kitten, and has had ocular discharge since. And the history before that is unknown. All right. So looking at this gross image here, there is a front of the eye here and back of the eye here. You can see the little nubbin of the optic nerve. So the corneal surface is basically replaced by this thin layer of pigmented tissue, which, believe me, this is iris, and I will show you that histologically. There is also still a lens here. It is exhibiting a really severe hypermature cataract. And there's liquefaction and mineralization of the cortical lens fibers. Cataracts can be like this. They're basically like chalk to cut. The posterior chamber is really, really deep. You can see all these very stretched out and kind of flat laying ciliary body plica. So this is a very abnormal eye. All right, so let's take a look at the histology. All right, so the front of the eye is rotated 90 degrees clockwise, and it doesn't really look like normal cornea. There we go, you can see the front of the eye a lot better there on the subgross. There basically isn't any normal corneal stroma there. It's all just prolapsed iris, the whole cornea pretty much. You can see the limbus there with a conjunctival fornix, whole cornea absent, iris prolapse. And then we have that really severe cataract arrow in the center. There we go, there's the arrow in the center. And a really severe hypermature cataract pushed up against the back. I think this is like dynamic ocular pathology. You can kind of see those ciliary body plica almost as they were pulled towards the front when that eye lost its pressure and ruptured initially. Kind of cool like that. And the back of the eye, the retina is a little bit folded, but probably artifact. The front of the eye is where I'll show you most of the things. Let me try and maintain, yep, this should be the same orientation. So here we are at the front. And again, just proving to you that this is all just prolapsed iris. The only cornea that you can really see that's left is right here at the limbus. It's got that usual look where you can see the thicker, denser collagen fibers of the sclera kind of meeting the corneal stromal fibers, which are more sort of lightly staining and exquisitely parallel fibers here in the deep. So we have a little bit of cornea left right at the edges, and then everything else has just been completely destroyed, and the entire surface of the eye is now just iris. The other thing that has sort of reestablished barrier function in this ruptured eye is that there is epithelium that is now lining the anterior surface of this prolapsed iris. And that epithelium has some interesting characteristics. There we go. So you can see these little cells here and there in some of this epithelium that is on more or less the corneal surface where the corneal surface would be. And these are goblet cells. So it's a conjunctiva-like epithelium that is basically replacing where the corneal epithelium should be. I'll show you conjunctival epithelium when it is conjunctival epithelium to compare. So hold that image in your mind really quick as we go over here. So here's conjunctival epithelium. That's normal. It has lots of goblet cells. And we have a similar kind of conjunctival look to the epithelium that's covering sort of what has now become the corneal surface. So that is conjunctivalization. And that is one of the features we'll look for that kind of suggests viral infections, such as a herpes viral keratoconjunctivitis. So those are kind of the key features of this case. We have a large corneal perforation, which involves more or less the entire cornea with iris prolapse. We presume that the cornea is completely gone like that because of corneal necrosis. And there's corneal surface conjunctivalization, which is sort of suggestive of, although, you know, there's nothing that's necessarily pathognomonic for viral keratoconjunctivitis. So we call this early life eye disease, feline early life eye disease. And it is suspected that this represents a viral infection early in the cat's life that destroys the cornea, causes that huge corneal perforation and iris prolapse. And then in essence, the barrier function up front is reestablished. We actually have cases in the Coplow database of cats that have gone to 6 or 8 years of age even. They can get quite adult or old without actually having any obvious discomfort in this eye or any obvious endophthalmitis or intraocular infection, because that iris and that epithelium does do its job and kind of reestablish barrier function. So early life eye disease in a cat, presumed due to viral infection. Usually it's either herpes virus or calicivirus. There are some cases that we have evidence it was calicivirus that did it. Any comments? I usually always want to stop to ask for questions, but that's not how this works. So we can go to the next one. Okay. Another cat. We have a clouder of cats this morning. This is Pepper, a 14-year-old domestic short-haired cat, neutered male. Pepper, we got the right eye. There is a firm lobulated tissue swelling, parentheses, mass effect, temporally, which is painful on palpation. And there are multifocal areas of stain uptake over the surface of the eye. They previously did a keratectomy in this eye and an A-cell graft due to chronic keratitis and a sequestrum forming in this eye. There's also chronic keratitis in both eyes. This eye developed the mass effect though, and so they submitted this eye for evaluation. And as you can see on the gross view, we have one you're facing the eye as if the animal was looking at you, and then the hemisected view on the right. And you can see that roughly 80 to 90% of the corneal surface is completely replaced by this irregular surfaced tan white mass in essence. And on the cut surface, maybe there's a little bit of cornea remaining that has a bit of that optical clarity on the edges, but otherwise the entire cornea full thickness is replaced by this neoplastic tissue. And you can kind of see, so here's the iris leaflet here. Here's the iris leaflet there. You can kind of see what it looks like when it's normal on this side, the goldeny color of the iris, and then the ciliary body with the plica down here. On this side, though, there's this little white tan nodule that's sort of sitting right there in the middle of the ciliary body. And that's very suspicious. So we'll take a look at that closer. Moving on to histology. It won't go like that. Here we go. We'll put it exactly how we saw it in the subgross. And there's altogether too much purple in this corneal surface. You can see a little bit more of the normal, more in the front. We can see a little bit more of the normal corneal stroma on the deep layers. Put that in the middle. So sort of right down here, a little bit more of a normal corneal stroma, but it is very heavily vascularized. We can see the blood in that vessel from space. There is this abnormal, very cellular and basophilic tissue, replacing the entire surface of the cornea, or a large portion of it. The conjunctival surface invading into the sclera. It's in the episcleral tissues over here. And then, yes, it has spread inside the eye into the ciliary body, into the uveal tract there. So let's take a closer look at that. This time we rotated 90 degrees to counterclockwise. And here's the front of the eye. And when we look at this neoplastic population, It is these anastomose cords and trabeculae of neoplastic epithelial cells. So these are polygonal cells. There we go. They have distinct cell borders. They have pretty serious pleomorphism. There are some that are binucleate. There's a lot of mitotic figures here and there, as you may kind of catch your eye. So this is a carcinoma, and it's pretty poorly differentiated. It's showing us enough of the cellular morphology that we can be fairly confident that we have here more of these cords, so you can be convinced. Anastomosing cords. So it's showing us enough morphology and distribution type features to be confident that we're looking at a carcinoma, but that's about it. It's not telling us if it's an adenocarcinoma or a squamous cell carcinoma or anything else like that. And especially in a cat, the two kind of corneal conjunctival surface carcinomas that we probably see most commonly are conjunctival surface adenocarcinoma, which is thought to arise from kind of the limbal stem cells. There are those cells that have high proliferative capacity at the edges of the cornea and are part of why the cornea can heal so well when it gets scratched. So we think that that's what this tumor arises from. The other possibility is it could be a kind of poorly differentiated squamous cell carcinoma that isn't really doing the keratinization that would help us to definitively say that this is a squamous cell carcinoma. So two most common carcinomas that we would be looking at. And so ultimately that's what we gave as a differential, probably either a conjunctival surface carcinoma or adenocarcinoma, or a squamous cell carcinoma that's just not keratinizing well. It was completely excised from this kitty. And we don't know what relation, if any, the previous history of surgery would have had. We don't have anything to show you that was specific to the surgical procedures that this cat underwent. This cat also would have had a history of chronic inflammation in the area. So that's interesting to consider, but that is the diagnosis here. A very interesting, very extensive and invasive tumor. The prognosis also with these two differentials, a tumor that arose from the conjunctival sort of stem cells or the squamous cell carcinoma, they have a similar prognosis. They're both very aggressive locally, very invasive, and they can both metastasize, usually to the local lymph nodes first if they do. So ultimately the debate about which one it is fairly academic. So that's all for this case.
Sorry, I missed did they specifically talk about the third eyelid in this one? Or?
They say normal eyelids, although I'm not sure if they're referring to the eyelids and the third eyelid with that.
Yeah, because the conjunctival surface adenocarcinoma most often it not starts or initiates at the third eyelid surface and then spreads around. But who knows if that was involved or not.
We did say on our gross notes that the tumor especially was involving the ventrotemporal and ventral areas. So possibly, yeah.
All right. Yeah, without any clear involvement of the conjunctival surface in any form, I would favor squamous cell carcinoma.
Favor squamous cell carcinoma. All right. I still want to pause for questions, but that's not how this works. So we'll keep going. The last cat in our little clouder this morning is Tilly. Tilly is very interesting. So Tilly is a 12-year-old spayed female domestic short-haired cat. So Tilly gave us her left eye today. And there has been progressive iris pigmentation in the left eye since April of 2022. The clinician wasn't really worried in this case about this pigmentation. They say it looks still like iris melanosis, but the owner was very proactive and wanted to pursue enucleation, as OS is blind. And that is because there is a retinal degeneration that they were detecting on their funding exam. And the other interesting thing about Tilly is that the right eye was enucleated in 2020 with similar diagnoses, early feline diffuse iris melanoma or progressive pigmentation in the iris, and retinal degeneration, which was diagnosed clinically. Histologically, we didn't catch very many interesting features in the other eye, but this one, I have something to show you. So I didn't go and get the other slide for the last case, but we'll take a look at this one. All right, switch to that. We'll go straight to, we'll skip the subgrowth in this one because I think it'll be easy to see without it. What's going on? All right. So here's the front of the eye. The cornea is very quiet and happy. And here's the iris leaflet. We do have on this side a very open, very normal trabecular meshwork with these nice delicate pectinate ligaments. We have this layer of extra cells on the surface of the iris here, which we will look at closer. Interestingly, we also have this little cystic structure here. So there are kind of some thick-walled iridociliary or really ciliary body cysts in this case. We kind of suspect that these cysts or see them a lot in cases of trauma in cats, which is interesting to consider in this case, but ultimately hard to say what caused them. There's also some on this side. And again, just showing you on the other side how open and nice this trabecular meshwork is. Everything's doing fine up here. There's no reason for glaucoma in this eye that we see. There's no features of primary open angle glaucoma either, for that matter. So we have no reason glaucoma-wise why this cat's retina would have degenerated. So that's one piece of the puzzle that I want you to save for later. Before we move from the iris, though, let's take a look at those cells. And just as our clinician predicted, this was not very severe disease by the time of enucleation up here in the iris. Mostly these abnormal cells are lining the anterior surface. Pop that in. The anterior surface of the iris in multiple layers. There are these lightly pigmented polygonal to spindle-shaped cells. The nuclear features aren't very pleomorphic, nothing too exciting going on. They maybe just barely infiltrate the iris stroma. And so our cutoff for determining feline iris melanosis versus early feline diffuse iris melanoma is whether the iris stroma is actually invaded. Melanosis will be confined just to the surface. Melanoma will be invading into the stroma. So just barely invading enough to call it an early feline diffuse iris melanoma, but certainly still not very extensive in this case. And while we're here, just for fun, we have these lovely pheomelanocytes in the iris stroma of this kitty. Yeah, let's get higher. Cat irises, these just very commonly have more pheomelanin. They also will sometimes have eumelanin. In fact, there's probably a little bit of eumelanin over here, but all of this very light kind of golden brown pigment here, which kind of looks streaky in the cytoplasm of these cells. These are a normal residence of a lot of feline irides, probably part of their lovely kind of coppery colors that they'll sometimes have. And I just think it's lovely and thought we'd take a minute to look at them. But that's all. So nothing too worrisome in terms of this tumor. The prognostic features of feline diffuse iris melanoma that suggest a worse prognosis and a higher risk, at least relatively speaking, of metastasis. It can still be fairly low, the risk of metastasis overall, would be if there's tumor necrosis, if there was a mitotic count of 7 in 10 high power fields or more, and whether there was choroidal or scleral invasion, of course, none of which this tumor exhibits. So, but the reason why I have this case up here more so, we don't have an optic nerve captured in this section, but we have some retinal things that are very interesting. So sometimes I feel like ocular pathology is like a matter of counting. You know, you count, there's too many layers to the ciliary body epithelium, or you count, for example, the retinal layers. And in this case, there are too few layers. So we have a well-preserved and very nice nerve fiber layer here with a good number of retinal ganglion cells. There's lots and lots of them. But we only have one nuclear layer, more or less. And we have no photoreceptor segments either. All of that, the outer nuclear layer and the photoreceptor segments are gone. And we have a handy case in our clouder of cats this morning. So hold that image of that retina that you just saw in your mind while I scurry over to this slide. And this was that case that we just looked at with the tumor up front, and the back of the eye is good and happy. So we'll compare this normal feline retina to what we just saw. And so you can see now we have the outer nuclear layer and we have these nice healthy photoreceptor segments. And that's what it looks like normally. So fix that image in your mind again. We'll hurry scurry back over to Tilly's eye. So you can see the difference. And so we have a really severe outer atrophy of this feline retina.
See how
Yeah, let's do
the
that.
distribution of the whole thing. It's just not focal. That's an important feature.
That's also an important feature. Yes, it's not focal. It is affecting the entire retina. So we are coming in maybe a little bit better here, but so it's a little bit variable, but the whole thing, the photoreceptor segments are absent. The outer nuclear layer is absent. But there is a well-preserved nerve fiber layer. And we also, as we looked at earlier, have no reason for glaucomatous degeneration in this retina either. We didn't really need that because we see that this is an outer atrophy. Glaucoma-induced lesions would be inner atrophy. But it was worth pointing out, I thought.
And cats were specifically a ganglion cell loss more than anything else.
Right. Yes. Usually cats, unlike dogs, which can progress to a full thickness atrophy, for glaucoma, cats usually they preserve the overall structure of the retina and just lose the ganglion cells, which is a good point to make. So this is a really severe and extensive outer atrophy in this eye, clinically somewhat more impressive in the other eye than histologically, it seems. There was also degeneration in the other eye. So we usually think with degeneration like this of something ischemic. We can also think of something toxic in essence. So cats have fluoroquinolone toxicities, which can look like this. Cats have taurine deficiency, which is less common these days because most cat foods are well supplemented. But you can sometimes get cases, for example, if an owner is accidentally feeding dog food or something like that. So there are a couple of different potential causes that could have caused this degenerative change in this cat's retinas and caused this cat to become bilaterally blind. And then as an unusual bonus, also feline diffuse iris melanoma in both eyes. So I thought this was an interesting case.
Anything in the history that suggests any of that?
Nope, not that we have. They diagnosed the retinal degeneration, and we could try and call and see if we ended up pulling something about that, but not that we know. But yeah, very interesting. Let's change back over to the, and there's our diagnoses. All right. Shall I keep going? You want to switch? Okay.
All right, switching presenters now. It's me, Leandro, here. Next case we have is 6427, and I promise this is an eye. So this is Isabel, the 11-year-old Belgian Tervuren dog. It comes to us with a history of uveitis and secondary glaucoma with intraocular hemorrhage bilaterally that was identified early 2021. Unknown cause. Both eyes eventually became physical. Owner reported about a year later with the right eye enlarged and presenting what they describe as a large tumor. The left eye was still physical. So this is what we received. As you can see, the main thing here is to actually identify anything ocular in the sample. So let's start with what looks like a markedly degenerated lens right there. If you look around, it can follow what looks like sclera, maybe with a defect at its most posterior aspect. Sclera continues around and looks like it changes into potentially cornea. One useful thing to look for when we're trying to identify intraocular tissue is melanin, right? So if you look around here, there's a linear, darkly pigmented tissue here. This could be just chronic hemorrhage, but potentially also iris or ciliary body. And then you can see that there's a large defect in the sclera right there. And of course, this very large white to tan mass that effaces the whole intraocular structures and looks like it's infiltrating and effacing the sclera, protruding into the adjacent tissues, maybe some of the ocular surface here, some of the third eyelid. So let's see what it looks like on the slide. Got to give props to our histotechs because this one actually turned out impressively well. So hang with me here because this is not a small slide to try to figure things out. So let's, all right, keep going around. Apologize for those who have motion sickness. Here we go. So let's try to get our bearings here. We have lens, surface, so likely cornea, a little bit, sorry, what looks like the bulbar conjunctiva. Keep coming around. There's not, well, I think what I've identified grossly as pigmented uveal tissue, I think that's exactly what that is here. But let's keep that in mind. Coming around, we have borders of the tissue, which are likely sclera. There's some extraocular, what looks like extraocular muscle right there. There's a defect in the posterior sclera adjacent to the optic nerve, and that larger defect that I mentioned of the what looks like lateral sclera, right? And this large mass, a lot of basophilia. So everything that's blue here, these are cells. The lighter areas could potentially be areas of necrosis, edema, and there are areas of hemorrhage throughout. So let's jump right in. And let's start with a anatomically identifiable region of this eye. Let's see if I can get. All right, we're getting to, let me go the other way around. I'm sorry about that. This is too big, so we're going to start with a good orientation here. Okay, so here we go. Just to confirm, corneal surface, bulbar conjunctiva. Looks like the corneal stroma is replaced by fibrovascular reaction. And then let's get a little closer. Here is a fragment of Descemet's membrane and the neoplastic population of cells right next to a hypermature cataract, likely a lens capsule rupture. Let's see if we go, I'll use your imaginoscope here a little bit. We'll get to an area where there are squiggly linear basement membrane-like structures that are fragments of the posterior lens capsule. And if you follow it around enough, you might end up in an area where you lose the continuity. So likely a rupture posterior lens capsule here. There's a reason why I'm pointing that out right now, because we're going to come back to it later in terms of trying to put the pieces together here. But let's go and take a look at the neoplastic tissue. So this magnification, you can see that the neoplastic cells, they are forming some pretty distinct structures. By that, I mean, there are some cords, some potentially pretty defined acinar structures and trabeculae. So all the features I'm describing now are features that suggest epithelial or origin. But again, there are other tumors that can mimic this kind of arrangement, especially melanoma that can actually mimic anything, right? Again, turning your imaginoscope up, you might perceive some lobulation. So there's a lobule there, there's a smaller lobule there. So again, lobules are another feature of epithelial cells. When you look at the cells themselves, one might argue, oh, there's a lot of blood in between. Could this be something like a hemangiosarcoma or endothelial origin? The answer is potentially, yes, there are epithelioid hemangiosarcomas, but we'll keep that as a differential at this point. So neoplastic cells are relatively, well, there's some pleomorphism, but not a lot. Mitotic figures everywhere, a few here and there. We have to be careful because if you start looking near the remnants of the uveal tissue, which are here, you start seeing cells that might look like they have pigment. Well, they actually have pigment. So the question is, are these pigmented neoplastic cells, or are they just phagocytizing the native pigment? So to answer that, we move away from the main mass, or the areas that are adjacent to the uveal tissue, and you start to see that pigment becomes a little less obvious. So karyomegaly, some cytomegalic cells, anisocytosis and isokaryosis. And just to confirm that the extraocular portion of the tumor is similar to the intraocular portion, let's jump around. So I'm kind of moving fast here because there's not a lot of ocular structures that are identifiable at this point. And you can see that by the time we get closer to the sclera where the choroidal uveal tissue should have been, you start picking up a little bit of pigment or melanin pigmentation, kind of confirming that that was probably the choroid. And so here we are at the extraocular portion of this tumor, the extension. Sometimes it's useful to look there because when the tumor grows inside the eye, there might be a lot of compression and necrosis because of ischemic artifact. And when they reach the outside portions of the eye, they're not necessarily constricted anymore to that area, and they have more space to expand, let's put it that way, and they might show their true colors. So here, again, similar situation, kind of pleomorphism is accentuated, some lobular arrangements here and there. There's this collagenous sort of background. Some of it might be native collagen. And in areas, these cells start forming streams and bundles and look a little bit more elongated, like you would expect from a sarcoma. But this is not atypical. Again, areas of necrosis everywhere. So we're dealing with a pretty malignant neoplasm. Just to show the margin. So here's the surface. We have an ulcerated necrotic surface with a cirrocellular crust formation. For those of you who like bacteria, especially contamination, here's a some clusters, colonies of contaminating bacteria on the surface, probably suggesting that this was exposed to the elements or to the ocular surface. And you can see the surgical margins are all affected. So at this point, our main differentials here are what we call a pleomorphic iridociliary adenocarcinoma. Melanoma is always on the menu, and we cannot rule out something metastatic to the eye or another type of surface-oriented carcinoma. The history is very interesting. So there's a history of bilateral ocular disease where both eyes became physical, right? And longstanding as early as 2021, but potentially more than that. The history of bilateral phthisis and the presence of lens capsule rupture in this eye, on the present eye, suggests that there might be an element of trauma here in this eye. And interestingly enough, pleomorphic adenocarcinomas, which are truly malignant neoplastic transformations of the iridociliary epithelium. It's a term that we kind of borrowed from the medical terminology, like the medical world, where these tumors develop in eyes that have either chronic ocular disease, long-standing ocular disease, or have a history of trauma. Like in this case, which we suggest bilateral trauma with phthisis in one eye, and bilateral phthisis bulbi to begin with, and then the development of the tumor in this eye. So a pleomorphic iridociliary carcinoma is still our main differential. I think we offer immunos. We haven't heard back, looks like, from them yet, but we could do cytokeratin by Menton. These tumors tend to be positive for both. And NSE might be another positive stain, a little less specific in this case, but a melanator without a malignant melanoma might be also useful. So here is our final diagnosis: poorly differentiated intraocular carcinoma with dirty margins. Our main differentials being the pleomorphic iridociliary carcinoma. Of course, we were not able to confirm glaucoma in a situation like that because all of the ocular tissues were effaced. Prognostically speaking, the most important thing here for cases like that are clean margins. Unfortunately, the margins were dirty, both the orbital content or the extraocular portion of the tumor, but also at the optic nerve. We were not able to identify the optic nerve. We saw that defect and next to the optic nerve, and that is also a bad prognosis in terms of a potential infiltration of the tumor towards the brain, kind of following the optic nerve track back to the brain. Also, pleomorphic iridociliary carcinomas, they can metastasize. We have cases where we have identified metastasis to regional lymph nodes and the lung, most likely. So probably suggested a close follow-up in this patient because of that. All right, so let's keep moving. Our next case, we have a horse for us now. This is Zelda. Zelda is a 16-year-old Tennessee Walker horse, and we have they have both female and male listed, but with Zelda, I'm going to go with female. They basically only describe an intraocular mass on the anterior chamber. And they were not sure about glaucoma. So this is what we received. This is Zelda's eye. And as you can see here, let me make it bigger. As you can see here, the cornea, lens, optic nerve, vitreous, and you can see the mass infiltrating and expanding the iris, potentially the ciliary body. There is some melanin pigmentation kind of throughout, but it's probably due to sectioning artifact when we did it, when we cut right through it. So we're mainly going to be focusing on that anterior ocular or anterior segment of the eye. So let me start here. Okay. Again, another large eye. So, here we go. Let's get our bearings here. So here's the anterior segment of the eye. We have cornea. We have some identifiable iris leaflets or iris irido tissue. Here's the pupillary membrane and the aforementioned mass. There is some identifiable ciliary body plica, and likely we're going into the iridocorneal angle right there with some of the larger pectinal ligaments a little bit more obvious. Here, again, iris leaflet, some pigmentation there, either free melanin or pigmented cells or neoplastic cells. We'll take a look at that. Again, ciliary body. Here's the cornea, kind of folded there in the middle. And then we go back to the back of the eye, large equine eye, and things look relatively okay, but we'll double check that. We also have an extra section of that angle, trying to sample another portion of the mass, probably either the temporal or the lateral portion. If you can see, we got a little bit more omnioplastic cells to look at. So let's jump right in, a little closer. And as usual, I'm gonna turn it around because I started at the wrong side. Okay, so just to recap where we are anatomically speaking, cornea, here's a corneal fold, so don't, this is artifact, I'm not gonna make much out of that. And again, the contralateral iridocorneal angle with the iris and some pigmented debris. It doesn't look like we have many cells in there, so that's likely the downside. And this is likely all free melanin pigment that end up draining to the contralateral iridocorneal angle. And here is our mass. So we have a relatively well delineated and heavily pigmented mass, mostly infiltrating the iris stroma, trickling down the iridocorneal angle, protruding into the anterior chamber and contacting the contacting Decimus membrane surface. It's partially effaced in the iris. You can see there's a little bit of a corpora nigra right there, or what's left of kind of an atrophic corpora nigra. So the diagnosis here is not that big of an issue, right? We have a pigmented neoplasm in the iris, and until proven otherwise, this is a melanocytic tumor. So let's prove it otherwise. No, sorry. Let's prove that this is a melanocytic tumor. So what we have here are sheets of polygonal cells with variable cytoplasmic pigmentation with melanin. Some are have a more obvious nuclei than others, where the pigmentation almost effaces the whole cellular morphology. Not a lot of mitotic figures, but a relative amount of pleomorphism with some cheiromegalic cells, some distinct nucleoli, right? Very repeatable population throughout. So, as I said, the diagnosis here is pretty obvious. This is a melanocytic neoplasm. We tend to call those in horses melanomas, for lack of a better term. They tend to, we don't see a lot of morphological variation in terms of being able to make a distinction between melanomas and melanocytomas in those cases. And there are often two types of syndromes that we see. We either have the classic melanomas of gray horses, where the ocular tumor is part of the systemic disease, where they have multiple melanocytic tumors everywhere in the body, in the skin, more likely, or it's kind of a solitary ocular melanocytic tumor, right? So this is important, and that is kind of a clinical differentiation where, unfortunately, we can assess histologically. Interestingly, there's this fibrotic reaction at the periphery of the mass where it contacts Decimus membrane, right? So this could be extension of a, fibroblastic reaction from the trabecular meshwork, or a ruptured Decimus membrane somewhere. So let's take a close look at Decimus membrane. Doesn't look like there's an obvious rupture in here. And here, just to show you guys the contralateral iridocorneal angle, there's some pigmentation of the iris stroma there, but it's hard to assess because it's not obviously neoplastic, and we don't know how pigmented this iris was to begin with. In this horse, we only have this one snapshot sort of in time, so it's hard to define. Oh, I got it. If this is pre-neoplastic or not, but we do have lots of pigmentary debris in the iridocorneal angle. Megan's pointed out to me, we have an additional section of the cornea, which we want to take a look at, because that fibrosis could potentially suggest a Decimus membrane rupture. So we're coming around. Okay. Oh, so that's like the choroidal portion of it. Okay. Yeah. So we saw there was a choroidal bump also identified grossly, and we submitted that separately. And yeah, here it is. Not the best section, but here it is. another fragment of looks like similar tumor. It's kind of a cool presentation, right? Because this looks pretty far away from the main mass. Makes you wonder if there's this extension of that main tumor sitting inside the eye, or it's a totally separate choroidal melanoma, making the case that this horse had 2 intraocular melanocytic neoplasm. It would be great if this horse, it would be great if this horse were gray, and then it will make actually more sense to have developing multiple melanocytic tumors throughout the eye or and the skin potentially. Okay.
I considered calling to ask, but I thought it might be a little intrusive.
Yeah, that'll be fine. I mean, so anterior uveal and choroidal melanoma with clean margins, focal breaking decimus in brain dorsally, trabecular mesh pigment dispersion, and full thickness retinal atrophy of unknown significance. This could be glaucoma. So we suggested a presumed secondary glaucoma in this case. So as I said, the main thing at this point will be to try to associate the presence of the melanocytic tumor in the eye with a potential systemic melanocytic disease in horses. Unfortunately, we don't know that. Speaking of melanocytic stuff that we do not understand perfectly, here's the other one. That's a fun one, I think. At least confusing enough to be interesting. This is Higgins, the 8-year, 4-month-old neuter Newfoundland dog. So we've got a Newfie here. We got the right eye, and they describe a red lobulated mass arising from behind the ventral iris since January of this year. In May of this year, the ophthalmologist suspected this was a hemangioma, but also found a dark pigmented retinal mass adjacent to the optic nerve. On July of this year, that choroidal lesion underwent laser ablation. In September, the mass grew again, and it's now about 5 times the size it was to begin with, but without no obvious extension into the retrobulbar space, and ocular ultrasound was normal. Of course, this dog is from a veterinarian, as are all dogs and all pets that have very complicated disease. We call these DVM positive patients. So this definitely DVM positive. And as you can see here, so let's look at the gross image. As I said, interestingly, you can see that there's pigmentation everywhere. The iris ciliary body is markedly expanded and pigmented. You can trace down the choroid. There's pigmentation in the choroid also. And right next to the optic nerve, almost effacing the optic nerve in this case, this what we assume is what they describe as the choroidal pigmentary mass or pigmented mass right there, right? Lens looks okay, despite of what's going on around it. So let's start with, well, let's start with the one with the optic nerve. So we have 2 sections. We have a superficial section because we wanted to sample the mass here. And then we have a deeper section where we went all the way to the optic nerve. So this is the one with the optic nerve, just for anatomical bearings sake. Let's put it that way. So here's the corneum. Here's the lens, the heavily pigmented, kind of distorted iris leaflets and ciliary body, heavily pigmented choroid, got the optic nerve, and the beginnings of a distorted peripapillary choroid here, where we're going to take a look at the original section to check on the mass. So first thing to notice at this magnification, there's not, rather than the potential mass. So let me show you what the mass looks like in the optic nerve before we move on. It will be easier to understand. So this is the superficial section, right? Showing a more mass-like lesion adjacent to the optic nerve. So rather than, besides this here, there's nothing else that obviously look like a well-delineated mass. It's more like the diffuse expansion of the uveal tissue. So let's go back to the optic nerve section. take a look at that closer, and then we'll move on to the next one. So if we look around, as I said, an expanded, moderately distorted base of the iris, ciliary body, mild distortion of the trabecular meshwork and ciliary cleft, but it's still identifiable aqueous drainage structures. If we move to the other side, I got a similar situation here. So let's jump right in. So here's a good area. The camera really always have a hard time adjusting to heavily pigmented areas like this, but we'll make the most out of it. So what I want to show basically is the fact that most of the cellularity here is made of round, heavily pigmented cells without a lot of distinct or a distinct double population or distinct nuclei or identifiable, neoplastic features. That's one of the features of this situation here. So I think it would be easier for me just to get back into it and describe the thought process a little bit better. So when we have pigmented eyes like this, there are a few possibilities for diagnosis, and we go from the more benign ones to the more malignant neoplastic ones. So if you start at one end of the spectrum, the most benign or normal end of the spectrum, we have what we call heavily pigmented eyes. Those are the eyes of dogs that are heavily pigmented and that present darker, normal and anatomically normal, darker uveal tissue, iris, ciliary body, and choroid, right? If there is any distortion of this tissue, like we're seeing here, there's expansion of the base of the iris and the iris stroma, expansion and mild distortion of the ciliary body, we need to assess, or we need to be aware of the potential of this being what we call uveal melanosis, right? It's a non-neoplastic distortion of the uveal tissue. And with uveal melanosis, what we may have are the presence of these round, distinct round, heavily pigmented melanocytes like we're seeing here. The next step over will be a melanocytoma. And in order to make that diagnosis, we look for the presence of either a well-delineated mass or what we call a double population of cells, where you have round, heavily pigmented cells along with fusiform pigmented cells, right? So in this case, we're still melanosis. We don't have a well-delineated mass in this area, right? Nor we have the double population of cells. If we have that, then we call it melanosis. And in order to upgrade from melanosis to a melanoma or a malignant melanoma, we need to see 4 or more mitotic figures in 10 high power feuds, right? So for now, what we have is a uveal melanosis, right? None of that has a double population of cells, but there's distortion of the uvea. The choroid is heavily pigmented. If we only have this choroid, we'll probably be on the heavily pigmented eye sort of category. But then we move into that area of the choroid next to the optic nerve. So if you only have this section, right? Sorry, let me go back one. Have a nice section of the optic nerve. Optic nerve actually looks pretty nice. The pigment that we're seeing here is likely the pigment that extends into the lamina prevosa. The lamina prevosa is an extension of the choroid and the sclera here. So that's likely what we're seeing there. So if you only have this section, looking a little closer, we mainly have the same, round, heavily pigmented cells without a double population. But let's go back to the initial, the initial section that we have, where now we have what looks like a well-delineated mass, right? And this strongly suggests that we have two things going on, both a uveal melanosis and a choroidal melanocytoma. Interestingly, if we look around, there's mostly population of cells, the one round population of cells, but here and there, if you use your imaginoscope, you start seeing some of the fusiform cells around, right? It's not a slam dunk, it's not obviously neoplastic, but we decided to go with that just because it's forming a more well-delineated mass compared to the adjacent choroid. Another interesting feature, every time we see things like that in dogs, one of the things that I like to do is to look around at areas where you wouldn't expect to see melanin. For example, the sclera, and it is a very subtle change, but if you look at the sclera, in this case, you start seeing individualized normal melanocytes kind of just around. And the cool thing is that sometimes if you look around, you find them coursing through and adjacent to nerves like that, or vessels. So here we're pretty far out, and you might see them surrounding peripheral nerves. This could be kind of adjacent to the optic nerve, so we're going to kind of ignore that area. But if we keep going at the sclera, here's another example of a scleral nerve with excessive or pigmented or normal melanocytes tracking through, and it's kind of spread around the sclera, and you can see that there's not a lot of infiltration of the sclera especially here where the choroid looks relatively normal, right? This is not infiltration of the melanosis or the tumor. And if you go back forward to, if you look at for example, the limbus here, it's often pigmented, but here's a little bit more pigmented than usual. And sometimes if you look at the choroid, at the bulbar conjunctiva, you see that similar pigmentation or the distribution of those pigmented cells around. So we started calling those guys, just for lack of a better term, or just for the sake of trying to identify them as atypical, or dogs with atypical pigmentation. So here is the final diagnosis of this one, and I'm wrapping it up. So uveal melanosis, heavily pigmented eye with diffuse atypical neuroretinal, perineural, and stromal pigmentation of ocular and orbital connective tissue of unknown significance. And we got the melanocytoma / extension of the uveal melanosis. So the interesting thing about this guy is we've seen this pattern of pigmentation, and now we actually published one case of a dog that had half of his head was pigmented, and the other half was not pigmented. I think that one was a boxer. And we think this could potentially be part of what is called in humans nevus of Oda, where these animals and these people, they have atypical patterns or migratory patterns of melanocytes through the embryological development, right? And we know the melanocytes are from neuroectodermal or neurocrest origin, so they might migrate through along with peripheral nerves and vessels throughout the eye, throughout the tissues and around the eye, and then you end up with this pattern of heavily pigmented tissues around the eye. The dogs that we describe and that we have identified with this pattern, sometimes they come with multiple melanocytic lesions in and around the eye, like this one that had melanosis, potentially melanocytoma. You had other dogs that had intraocular melanocytic tumors plus conjunctival melanomas and conjunctival or eyelid melanocytomas at the same time. So we think that a typical melanocytic migration might predispose these dogs to developing multiple melanocytic tumors in and around the eye.
What was the human condition you referenced just now?
Nevus of Oda. Oda is OTTA, the Japanese name. And I think there's a very nice paper published on FedOp with multiple cases of nevus of Oda, I think from Europe. Very nice case, and that came right after that first case that we presented. We didn't call our case Nevus avota, but it really fit the pattern. Okay. So thanks for coming over. Thanks for spending your Wednesday morning, afternoon, or night, depending where you are with us. And see you guys in 2 weeks.
Before we shut out, but do you think all melanosis cases are related to atypical pigmentation or just
No.
some of them?
Yeah, just some of them.
Yeah. Go ahead. You
Yeah.
said it. Okay, cool. That's it. That's all the questions.
All right. You guys have a good day.